surface of the eye. So you have two surfaces, so any of the surface can get affected. And then when there is a smoothness is lost, like as in astigmatism or any of the eye conditions where it gets injured or if there is a scar, etc., there will be alteration of the corneal surface. This can result in a condition called as irregularity of the cornea, which gives us to irregular type of astigmatism as well as sometimes it can scatter. So the main pathological conditions characterized by keratitis, that means any inflammation in the cornea, and corneal ulceration and scarring. These three things can occur. Okay. When you call it as keratitis, it can be called as superficial keratitis and deep keratitis. Okay, superficial keratitis is one of the most important things you have to know is when the cornea up to Bowman's membrane or Bowman's layer, if it is involved, it's called as superficial keratitis. That means only the epithelium is involved. So in such kind of cases, there will be small discrete patches, and then it can small punctate spots will be seen. It is very characteristic of adenoviral keratitis. Adenoviral keratitis is an epidemic keratoconjunctivitis which occur in almost in the transition of the season between rainy season and the winter or the summer to rainy season, etc. So you can see that's called a viral keratitis caused by picornavirus and other viruses like. So when it is deeper to the desmoid membrane, Bowman's membrane, stroma is involved. That's called as stromal keratitis or deep keratitis. So deep keratitis is again, it is stromal. It's also called as interstitial keratitis. Where is interstitial keratitis most commonly found? It occurs in the congenital syphilis, where the cornea will have a very steamy type of look, and then if you put a drop of steroid, it totally clears off, and the person will be able to see. So that's very important. So the endothelial keratitis is because of endothelial cells get involved. So epithelial defect can be demonstrated how. If you want to see if a person comes with an injury or if a small ulcer or whatever, whenever you want to treat any corneal condition, particularly any person who presents with clinical features of corneal condition, their mostly important symptom is lacrimation, increased lacrimation. It is usually reflex in nature, and there will be redness of the eye, photophobia, foreign body sensation, and then pain, and then visible whiteness of the cornea. Okay, visible whiteness means already the cornea is going into a little bit of opacification. So if you can see any of these conditions, you must be able to ascertain whether the cornea is ulcerating or is it having an epithelial defect or is it taking up any stain. There are some stains which are most commonly used to detect if there is an erosion of the epithelium. Erosion of the epithelium is very important, or any epithelial defect is also very important to recognize early. See that if you attending the ophthalmoscopy, you'll be seeing there are strips. Previously, we used to use fluorescent solution medium for pseudomonas. So we have abandoned the solution for staining the cornea. We are getting strips, small filter paper strips which are dipped in the fluorescent solution. We apply their dried and kept. So you can make it on your own by adding a fluorescent solution and dipping the strip and then drying it up. That particular thing is kept in the conjunctival cul-de-sac, where you will see a defect as a blue-green defect on the cobalt blue filter on the slit lamp. Or usually it stains where exactly the epithelium is not intact. The epithelium is not intact. You can see that corneal cells, the epithelial cells are denuded, and then underlying stroma or the Bowman's membrane catches up the strain, and then it clearly points out where exactly the defect is. So you can easily diagnose corneal ulcer or a corneal epithelial opacity, wherever epithelial defect, wherever it is. So if you can see an erosion or an abrasion on the cornea, sometimes you go around and sometimes you rub your eyes, it can cause slight abrasions. If there is a small particle in the eye, you rub it, you can get linear abrasions on the cornea. So these can be, they are usually not seen routine examination of the cornea. You will only, if you dye it with fluorescent, and then the fluorescent takes up, and then you can see linear opacities, linear staining of the, yeah, that's very important. And then loss of epithelium surrounding the cornea. Loss of epithelium surrounding the cornea is called the corneal ulcer. What is corneal ulcer? Corneal ulcer is usually an infective thing. So it is ulcerated. So if before ulceration, if you can see a small epithelial defect, you can simply ask the person to take antibiotic. And then how the cornea heals is, it heals by a method called as sliding of the neighboring cells onto the corneal epithelium. So sliding is a very important phenomena in the healing of very, very superficial corneal ulcers. If that corneal ulcer gets abrased and that infect and inflammation around the corneal edge of the cornea, where that is called the infiltration of the corneal ulcer. That is where you can find outpouring of leukocytes, and appearance is more or less yellowish or dirty white in color. That is the advancing edge of the corneal ulcer. That's a very important thing. And ulcers can be infective and sterile. Sometimes ulcers can be sterile also because the number of antibiotics have been used, but still it progresses. So I'll talk about the sterile ulcers later on. Then ultimately the inflammation will lead to loss of corneal tissue, and then they will arrange and cicatrize and then produce a various degree opacities or scars. So usually corneal opacity, when we find corneal opacity, we usually keep it as a case for you. There are no more long case and short case. All cases are carry equal marks. So you'll be asked to see 2 or 3 cases. So all the cases you have to write in full. So whenever you see a corneal scar, we'll usually keep it for you in the practical examination. So you need to know everything about the corneal scars. So as I told you, there's very important thing is there's a photophobia. When there is a corneal involvement, it is usually photophobic. So the person will not be able to see light. He'll quickly close the eyes, and then the mechanism of this photocoagulation, photophobia, is a stimulation of when the epithelium is denuded, there's all the nerve fibers will get affected, the superficial part of the cornea, and then those are the terminal branches of the trigeminal, ophthalmic division of the trigeminal nerve. So this is the thing which causes a lot of photophobia. So when you attempt to separate the lids and see, the fellow will squeeze, and then the intense blepharospasm you will not be able to examine. This occurs in majority of the injuries. When you are seeing injuries, you see a lot of blepharospasm. So if you can anesthetize those nerves, you'll be able to examine properly. So you xylocaine drops or a paracaine drops. You put one drop into the conjunctival cul-de-sac, the person will be able to open the eyes and you'll be able to see and diagnose whether there's a foreign body or an epithelial defect or a corneal ulcer for that matter. So this blepharospasm is completely diagnosed with anesthetics. Surface anesthesia, it's called a surface anesthesia. And then common signs of corneal disease are loss of transparency, a very, very important thing. the thesis loses transparency, and then as soon as it loses transparency, usually the patient diminishes, and there will be circumcorneal condition because of some part of the iris and the ciliary body also gets infected and inflamed, and then loss of smoothness of the surface. So if anything, any scar is formed, all the smoothness of the surface will be lost. So there will be irregular astigmatism. Surface irregularities are explained. How do you know whether they are surface irregularities or not? You take a torchlight, or you just ask the person. I think is very, very transparent cornealoplasty, and this can be because it is present before the Bowman's layer, or just Bowman's crystal wall can produce a nebular type of cornealoplasty. If such kind of opacity arrives, it can, how do you diagnose it? You will see all the details of the inside of the eye. That is a very important thing you have to remember. Then macular cornealoplasty, nebula macula, glaucoma, and adherent glaucoma. Okay. Nebula, after seeing the nebula, it can be macula. Macular cornealoplasty is a small area of the cornea becomes very dense. So the light rays which are passing through that particular macular area some iron deposition from the tears. So in establishing, you must always see that eyelids, how they are present. Is there any blepharitis? Is there any tear film abnormalities? Which is that when we deal with tear film abnormality, we'll try to tell you about that. But tear film is very important lubricating substance and a nourishing substance for the corneal epithelium. It is very important that you always try to see whether there is any problem with the tear film in the health of the cornea. Now we'll go into the, without going much into the other smaller details, I want you to go into the corneal ulcer proper. Hello. So corneal ulcer is an infective condition of the cornea. So that is divided into various types of keratitis. Wherever there is a condition or there is inflammation involved, and it can be due to bacterial, viral, fungal, chlamydia, protozoa, and spirochetes. All these things can affect. They have keratitis looks different to viral keratitis. Viral keratitis looks different to fungal keratitis and chlamydia and protozoa. All these things look different to each other. So it is very important that you have to distinguish these things in order to correctly treat the patient. So what is corneal ulcer? It is a discontinuous of the normal epithelial surface. So it is a necrosis of the surrounding corneal tissue. It is written as necrosis, yes, because the necrosis occurs because there is a mucocyte infiltration. If it is present as a grayish-white zone surrounding the particular epithelial defect. So that is, if that is present, the corneal ulcer is active. If that is coming down in what they call it as the length or the breadth of the particular infiltration zone is coming down with your treatment, that means the corneal ulcer is responding. So it is pathologically characterized by edema. There will be inflammation. All the inflammation will cause edema of the cornea. And you see, edema is imbibition of water into the cornea, and then until that infiltration you can see as a grayish, yellowish or dirtish white zone surrounding the ulcer cornea. So cornea is exposed to atmosphere and is prone to get infected easily. So minor infections, normal defense mechanism present, tear lysozymes, as I told you, and beta lysine and other protective proteins will keep on protecting and moisturizing and eyelids are one of the important things which protect the cornea from getting any noxious injuries. So even then, the tears play a major role in washing out any foreign body. Whatever sticks onto the cornea will be dislodged by the tears. So other local defense mechanisms are if they are jeopardized or if they are breached, some host immunity is compromised, and the causative organism like viral keratoconjunctivitis or suppose the AIDS patient, they have a compromised immunity, they'll get all types of viral infection of the cornea. So in such kind of conditions, the patient, if the organism are also virulent, like in epidemic zones, you get virulent organisms. Like such kind of virulent organisms like pseudomonas, right? They affect the cornea and they also invade the intact cornea. Monococcus and pseudomonas, they invade, they affect non-defective cornea also. If the host has got less immunity, it penetrates and produces a corneal ulcer. So damage of the corneal epithelium, infection of the eroded area, Neisseria gonorrhea, corneobacterium, diphtheria, Neisseria meningitidis. These things are the things which can penetrate into the intact corneal epithelium also. So it's very important. So corneal epithelium is damaged because if the corneal epithelium is damaged because of the corneal abrasions which will occur daily in the alien doubt, and if they are misdirected cilia or a small foreign body which is not recognized. Sometimes people come after 1 week saying that I'm having red eye, red eye. You see, we can see a small metallic foreign body embedded in the stroma of the cornea. Misdirected cilia are usually a case of trichiasis, which is consequent to trachoma. Concretions are small calcareous bodies present in the loop of Henle. They keep on rubbing on the cornea. Trivial contact lens trauma, whereas if they have very long nails, it can infect the cornea to produce abrasions. Now, epithelial drying, as you see in xerosis and exposure keratitis. If the fellow has got facial nerve palsy, the fellow will not be able to close eyes. And then xerosis is very important that in vitamin A deficiency, you can see cornea gets affected very commonly. Necrosis of epithelium as in keratomenacia. Where do you get keratomenacia? Sorry. If we have vitamin A deficiency, so desquamation of the epithelial cells as a result of corneal edema causes bullous keratopathy. It's a very important thing because cornea suffers from standing swelling. That water accumulates underneath the epithelium and can produce small bullae. When the rupture is a very, very painful condition. This bullous keratopathy is most commonly seen after inadvertently and wrongly performed incision in the corneal surgery when you enter into the epithelium of into the cornea by the blade. Epithelial damage due to tropic changes such as neuropathic keratitis, like I said, facial nerve palsy. So we need not go through this side. So the source of infection can be exogenous infection or from the ocular tissue itself. Suppose the person has got dactylocystitis and then you wanted to operate on the cornea. Or if you want, there is a local material, locally available, a lot of pus and septic material present in the sac. So all the sacs must be operated first. That's why we do a syringing of the sac. So that is a very localized infection. So if there is any tissue, suppose there is a localized foreign body, and if there is a pterygium, etc., that can attract sometimes an infection at the end. Endogenous infection can produce sometimes a corneal manifestation. So, ' Most of the time, it is usually conjunctival cul-de-sac, lacrimal sac-like dacrocystitis, infected foreign bodies, and from infective vegetable matter. Vegetable matter, you have to be very careful. When you want to inquire about the history of the corneal ulcer, you must ask how you got that ulcer. And the fellow, if he gives a history that something hit his eye, some vegetable foreign body, రైతులు వాళ్ళు ఉంటారు కదా కుప్పలు నూర్చినప్పుడు దే ఎగరేస్తారు ఇలా చేట పెట్టి that small grain of rice husk can go and lodge on the cornea and it produces a fungal keratitis, which is very resistant. So infected vegetable matter is very, very important to know. And you must also see what type of material is present. It produces the exogenous source of corneal ulcer. Look at this figure. You can see that there is an iron foreign body lodged exactly in the parapupil area, which is infiltrated, which is produces a small ulcer. And then how do you know that it's formed an ulcer? You can see that surrounding that particular epithelial defect with the foreign body sitting on the epithelial defect, surrounding, you can see a whitish area. That is where there will be leukocyte infiltration. And that infiltration is spreading onto the layers of the cornea. If this is present, that means the ulcer is active. You have to remove the foreign body, then only the ulcer will heal. And for that, you have to remove that particular iron foreign body. If you don't remove the iron foreign body, it can go, eye can go into siderosis. So all the iron foreign bodies which are present most commonly in people who work with lathe machine and also welders. Majority of the welders will report with small iron particles on the cornea. And this particular iron particle should be removed in toto. There will be remaining rustring after we remove the foreign body also. The rustring also should be removed to effectively treat the corneal foreign body, such kind of iron foreign bodies. So depending, and then you have to treat with antibiotic solution. Okay. See, this is dacrocystitis. You can see predominantly the nasal region of the left eye, or for you it may be right eye. Usually, if you see from the other side is left eye, there's a small saccular swelling, which is there's no medial canthus, it is swelling. So if you firmly press, a little pressing on the particular region, you'll get pus through the canal into the conjunctival cul-de-sac. This is a very dangerous condition. This is acute dacrocystitis. There's a chronic dacrocystitis, you have to do DCR operation. Okay, in acute dacrocystitis in children, usually responds with antibiotic, systemic antibiotic, and local antibiotic drops with anti-inflammatory preparations. So usually, if there is a corneal ulcer, you can see a circumcorneal condition. Circumcorneal condition and conjunctival condition, there's a small table in your textbooks. You are required to read how to distinguish between those two. Because circumcorneal condition, the vessels are radially, and in conjunctival condition, the vessels arborize. They are not radial. They are like straight lines. They are dusky red in color in circumcorneal condition, because usually when the corneal epithelium is injured and it produces the ulcer, the infiltrates also go into the sclerostroma and of the uveal tract, and the endothelium of the cornea can also get affected. Therefore, you get a uveal reaction. Okay. So endogenous, usually corneal ulcers are very rare, except in endothelitis. It's a different condition which is beyond the scope of your undergraduate knowledge. So we don't go into endothelitis. So these are all the common bacteria associated with corneal ulcers: Staphylococcus, Pseudomonas, and Streptococcus, pneumonia, and then E. coli, Proteus, Klebsiella, gonorrhea, and then meningitis, diphtheria, all these things. So they cause 4 stages. They are described in 4 stages: infiltration, active ulceration, and then regression and cicatrization. You remember what are the 4 stages of corneal ulcer? You must be able to tell this in your oral examination. First is infiltration. So it depends, the corneal ulcer infiltration depends upon the virulence of the infecting agent, and then post defense mechanism and the treatment received. So some of the ulcers can be treatment resistant also, because number of antibiotics by the quacks are employed. By the time he comes in, no common antibiotics. But moxifloxacin or ciprofloxacin is being prescribed by majority of the quacks, that we are getting resistance to such kind of antibiotics. So infiltration, you can see infiltrating around the corneal edge. Active ulceration means the epithelium starts shedding. And then after you do antibiotic treatment with um, with artificial tears and then cycloplegia, you can see regression. The infiltration starts regressing, and then you will be able to see less and less of grayish line, grayish infiltrate around the ulcer. And then it cicatrizes. Once it damages the Bowman's membrane, it usually produces a scar. Okay. So progressive infiltration will lead to stage of active ulceration, stage of regression, and stage of cicatrization. Okay. So usually progressive infiltration or ulceration, the ulcer gets the shape of a small saucer type of ulcer. Walls project above the normal surface. You can see carefully with a slit lamp or a small beam thrown. If you throw a torchlight from one side, you can see small edge and then grayish zone of infiltration. Hypopyan. Hypopyan is a sterile pus. Hypopyan does not have any, it's just infiltrate or exudate in the antechamber angle, antechamber lower angle. You can see a horizontal line. Hypopyan. In fungal ulcers only, you can find fungal hyphae. In bacterial corneal ulcers and in viral corneal ulcers, you don't get in the hypopyan, it is sterile. Even if you take the corneal ulcers hypopyan, you aspirate it from the antechamber, you don't get any type of organism there. Okay? So it usually progresses laterally and also deeper. So the more deeper the corneal ulcer goes, the more thinner the particular cornea becomes in that particular area. And then suddenly it can give a desmetocele, or a desmetocele, if it ruptures, can produce a ruptured cornea. Okay, ruptured corneal ulcer. So why desmetocele is formed? Desmetocele is a very tough elastic membrane. So intraocular pressure is more than the external atmospheric pressure. So it usually, the particular desmoid membrane will yield to that particular extent that it produces a small seal or a small sac-like structure that is just filled with aqueous. So if the intraocular pressure rises further, the atmospheric pressure decreases sometime, that is liable to rupture. So in treatment corneal ulcer with desmetocele seal formation, we usually give estrogen daily, so that intraocular is retained at a lower pressure than the atmospheric pressure. Cornea cannot give any better. In what? It's called a macula. Does not necessarily mean it's a bigger one. The bigger one, bigger opacity of the cornea. If half the stroma are inflamed or infected, it causes mucomatous. I'm sorry about my throat. I don't know how I lost it. Certainly. Then you can see small corneal facets in some of the ulcers. You can see the nebula, the macula, leukomatous ulcer, and when the ulcer perforates, what happens is there will be increased intraocular tension, and then they'll be pushing out the iris structures anteriorly. And then that particular iris, a plug of iris, comes and plugs into that particular ulcerated area where exactly it gave way, then giving rise to a small hole. And this, once the iris gets plugged in there, it's called as adherent glaucoma. This is usually asked in your examination. What is adherent glaucoma? So if the adherent glaucoma develops that way, it usually means that the ulcer actually is perforated and it is plugged by this iris pupillary border or iris material. And then that iris is richly vascular. And then this vasculature will supply enough nutrition to that area. So it quickly heals, but there will be a opacification where the ulcer was previously present. So you can see all the ulcer stages. Here there is the ulcer and there is the infiltration. Then it is usually a stage of infiltration, stage of ulceration. So these things are present everywhere in all the books. These are the zones which you have to see. So bacterial corneal ulcers and viral ulcers and fungal ulcers, they have got distinct properties we will address in the next class. Thank you.